infection nowadays is a mixed infection in over 90% of cases, mainly by staphylococci and streptococci. However, anaerobic bacteria are the main culprits overall, not only qualitatively, but also quantitatively compared to aerobic flora, for instance Streptococcus viridans. In the other mono-infections, beta-hemolytic streptococci, Staphylococcus aureus, and Pseudomonas aeruginosa are the most important organisms. The most common cause of an odontogenic infection can be found in pulp gangrene of a devital tooth or in diseased periodontium itself. Ubi pus, ibi evacua. According to this old therapeutic principle, the main treatment of an abscess of any kind is surgical decompression by incision. The top priority is to ensure lasting and adequate drainage. This therapeutic procedure will now be presented systematically in the following clinical cases. In this 32-year-old patient, there is already considerable swelling of the upper cheek region with the pain centered in the canine fossa. On palpation, the skin is hot and tense, and the collateral edema often involves the upper lip, the alanasi, and the eyelids. The typical loss of function of the eyelids due to the collateral edema is obvious. On vitality testing, canine 1-3 proves to be D-vital, and the radiograph also shows apical osteolysis. For differential diagnosis, the adjacent teeth 1-2 and 1-4 are included in vitality testing, which here give a clearly positive reaction. Extraoral infraorbital nerve block is required for anesthesia of canine fossa abscess. When palpating the infraorbital bony margin, the lower lid edema can be shown clearly by compression. After skin disinfection, the extraoral local anesthetic is injected paranasally in the direction of the infraorbital foramen while palpating the infraorbital margin until contact with bone is made. This enables adequate anesthesia while bypassing the inflamed region. The mucosa can also be infiltrated intraorally, directly over the maximum point of the abscess tangentially, which is apparent from the marked ischemia of the tissue.
Die Abszessmembran infiltriert. Das ist genau die Inzisionstelle. Gut.
Before the incision, the maximum point of the abscess cavity is felt, which can be found with certainty because of the fluctuation. The scalpel is inserted vertically in a slight curve as far as the alveolar bone. Here, the tense pus is released. The periosteal elevator is used to feel around inside the abscess cavity, and at the same time to elevate the periosteum from the alveolar bone in order to achieve definite drainage. The abscess cavity is then irrigated with a chlorhexidine-containing solution, and iodoform ribbon gauze is packed into the incision site for drainage. As the canine fossa abscess in this patient was well demarcated, without a tendency to spread, and the median corner of the eye with the angular vein did not appear tender, further systemic antibiotics were not needed. Another case of canine fossa abscess in an 11-year-old boy, in whom the abscess partially drained spontaneously through the gingival sulcus. The extensive collateral edema of the cheek, upper lip, paranasal region, and particularly of the lower lid is typical. The skin appears tense and shiny, reddened, and is very painful on palpation. Intraorally, the gingiva is swollen and coated with detritus, and here too, typical fluctuation is found on palpation with the forceps. Putrid serous secretion can be seen draining around the margins of milk teeth 6-2 to 6-4, a sign of spontaneous decompression. The symptoms of inflammation are thus already regressing, and the incision site only requires local infiltration tangentially over the maximum point.
Und du merkst nichts, ne? Das ist gut.
The adequacy of anesthesia can be assessed securely by the ischemic mucosal reaction.
Okay, so, jetzt nehmen wir das hier runter.
Here too, the incision is made horizontally, directly over the maximum point, at the junction with the mobile mucosa, with the scalpel vertical to the bone. This is followed by palpation of the abscess cavity with the periosteal elevator, and elevation of the periosteum from the alveolar bone.
Ja, sieht man auf dem... Ja?
The previously swollen and tense abscess membrane now appears typically collapsed and caved in. The abscess cavity is irrigated, and iodoform ribbon gauze is inserted for drainage. A canine fossa abscess not decompressed promptly can sometimes spread into the maxilla and there cause massive purulent maxillary sinusitis. The further complication of a periorbital abscess can arise through the infraorbital canal of the floor of the orbit. In this 10-year-old boy, highly acute odontogenic purulent maxillary sinusitis developed from the deeply destroyed molar 1-6. Spreading through the infraorbital canal, the purulent process erupted into the orbital funnel. In this typical compartment abscess, there is marked lymphadenitis, usually accompanied by pyrexia, marked edema of the cheek, and characteristic massive edema of the upper and lower lid. The medial angle of the eye with the endangered angular vein is markedly indurated and tender on palpation. As a result of the massive edema and accumulation of pus in the orbital funnel, protrusion of the eyeball occurs. Intraorally, only a slightly coated vestibulum without signs of fluctuation can be felt. In the posterior region, the deeply destroyed molar 1/6 can be made out as the odontogenic cause of the maxillary sinusitis. Active opening of the completely swollen closed eye is not possible even with maximum effort. The eye cannot be opened with help either, as the massively edematous conjunctiva of the eye prolapses outwards when the lid margins are spread even slightly, which is known as chymosis. As immediate treatment, the sinus is trephined through the canine fossa under anesthesia, and a long-term silicone drain is inserted. This drainage tube allows sinus irrigation several times a day so that the acute symptoms resolve rapidly on the obligatory high-dose antibiotic therapy. After just 4 days, the drastic decrease in the signs of inflammation and marked resolution of the overall dangerous situation can be seen. Impacted dentation can occur with any tooth where the eruption path is blocked. The lower wisdom teeth are the most often affected. Due to bacterial colonization of the pericoronal space, a pocket abscess then develops with a tendency to spread. If the inflammation spreads to deeper compartments, the submandibular lymph nodes are enlarged and tender on palpation. The angle of the mandible is usually slightly swollen and edematous. Even in the initial stage, subfebrile temperatures are not rare. If the inflammation has also spread medially to involve the medial pterygoid muscle, the typical picture of impaired function results with trismus in reaction to pain. Intraorally, the mucosa is swollen and edematous so that there are also painful traumatic bites in the intercalary line. The mucosa is erythematous, and when pressed with the mirror, putrid secretion is expressed from the pericoronal pocket. Inspection of the peripharyngeal space and soft palate is also important, as a spreading compartment abscess can be identified early from slight swelling in these regions. In preparation for the later surgical removal of the wisdom tooth, the inflammation is contained by daily irrigation of the pericoronal space or by a relieving incision. Fever and subsequent lymphadenitis are the early warning signs of massive inflammation with a tendency to spread, which necessitates systemic antibiotic therapy as well as local surgical treatment.
Ja? Wird man nicht gefühlt. Nochmal weit aufmachen.
The appearance of the patient with considerable malaise, fever, difficulty in swallowing, trismus, and circulatory lability signals all too clearly the acute inflammation which is beginning to spread. This perimandibular abscess originates from the dividal tooth 4-6, which has already produced obvious swelling of the cheek. On the other hand, the patient's general condition and mouth-opening movements are hardly impaired at all. A typical sign of a perimandibular abscess is that the lower edge of the mandible can always be felt completely. Intraorally, there is severe edematous swelling of the vestibulum in the region of the causative tooth. For incision of the abscess, terminal anesthesia of the vestibular mucosa directly over the maximum point is usually sufficient. Due to the steady increase of intraluminal pressure, spontaneous perforation of the abscess occurs distally at the maximum point. The horizontal incision is made just here, with the blade vertical to the alveolar bone. The periosteum also has to be divided. The abscess cavity is then palpated with the periosteal elevator, and the periosteum is elevated from the bone of the jaw. By spreading the incision further with an artery forceps, the contents of the abscess can be aspirated easily. Finally, prolonged drainage is ensured by insertion of iodoform ribbon gauze. Systemic antibiotic therapy is not indicated in this case, as there is no tendency to spread. In the 63-year-old patient presented here, upper lip abscesses occurred repeatedly, which reoccurred again and again despite antibiotics and stab incision. The history revealed that the patient had suffered trauma to the front teeth a year previously, when the left front tooth broke off. A foreign body can be felt definitely by palpation and by probing with a fine needle. To remove the foreign body, the upper lip is infiltrated sparingly from the oral side, so as not to make the search for the foreign body unnecessarily difficult. The foreign body is probed for the last time to determine its depth and position correctly. This is followed by targeted incision until contact is made with the foreign body, dividing the largely connective tissue capsule. Extraction with a fine claw elevator brings a fragment of tooth to light. The wound cavity is irrigated, and the wound is closed by primary suture. In this 32-year-old patient, a chronic granulating infection has developed from the deeply destroyed molar 3/6, which developed into a fistula from the alveolar bone through the periosteum and the soft tissues of the cheek out to the skin's surface. The patient had been receiving topical treatment from several dermatologists for 6 months. This fistula, located in the lower region of the cheek, is scarred and indurated and dips down in the shape of a funnel. On bimanual palpation, the navel-like retraction can even be increased. This is normally adherent to the underlying bone like a cord. Intraorally, too, the adhesion can be followed as far as the focus of the inflammation. Intraorally, the deeply destroyed tooth 3/6 is apparent, and the vestibular mucosa is erythematous and indurated with inflammation. Purulent secretion can be expressed from another fistula on pressure. Following conduction anesthesia, the first step is to extract the remnants of the roots with the elevator. The granulation tissue is then removed with the curette and forceps. The vestibule is then reflected by a vertical incision. The scarred fistula tract is then dissected from the periosteum with the periosteal elevator and removed with the forceps. Successful removal of the scarred adhesion is apparent promptly and very impressively from the relaxed and level skin surface. The intraoral wound is now closed by primary suture. Cervicofacial actinomycosis is the most common specific infection in the jaw area. This is a mixed infection by the specific bacteria Actinomyces israeli, which are gram-positive anaerobic rod bacteria and nonspecific accompanying flora. The typical clinical appearance of cervicofacial actinomycosis is characterized by a firm swelling adherent to the jawbone, which is often bluish livid in color. Not infrequently, small abscesses develop, which often lead to extraoral fistulas. The treatment of choice is wide incision of the subcutaneous abscess. The skin is disinfected adequately before the procedure. For anesthesia, tangential infiltration of the abscess membrane with a fine needle is adequate. The marked increase in pressure in the tissue can be seen directly from the ischemic reaction. For the incision, the skin is stretched with the fingers, and then incised along its lines of tension until the abscess membrane is open. Adequate evacuation and drainage are achieved by bluntly spreading the incision site with the artery forceps. At the same time, this avoids sharp injury to one of the numerous branches of the facial nerve. If actinomycosis is suspected, a swab should be taken for bacteriology and a biopsy for histopathological examination. After irrigation of the abscess cavity, ribbon gauze is inserted and an extraoral dressing is applied. Besides incision of the abscess, systemic antibiotic therapy is always required because of the specific inflammation with a high tendency for reoccurrence. The following table gives a proven therapy schedule. 15 grams of ampicillin IV for 7 days, then 4 to 6 grams of amoxicillin orally daily for another 14 days. The combination of clindamycin and metronidazole for 2 to 3 weeks has